Good morning, everyone. So my name is Payal Modi, and I'm from the University of Massachusetts. And today we're going to talk about from inequity to access, evidence-based institutional practices to enhance care for individuals with disabilities. This was a collaboration of multiple people, as listed here, from across the country who have all come together and kind of wanted to share the best practices and experiences caring for patients with disabilities and kind of how to improve care in your ED. We have no disclosures to report. Initially, we designed this as breakout groups, so we'll be adapting that a little bit today. We'll have an introduction, and then we'll have 3 different kind of groups talking and presenting. The first one will be for deaf and hearing impaired. The second one will be blind and visual impaired, and the third will be intellectual and developmental disabilities. And our learning objectives are to define ableism and describe how it impacts the healthcare of individuals, describe institutional barriers experienced by patient groups who with disabilities and who require accommodation, and then identify evidence-based organizational strategies and policies that promote equity.
Thank you. I'm just going to give a brief sort of introduction about disability. So what is a disability? There's many, many definitions for disability, but I think the one that's really important for us physicians to know and healthcare providers is the one that the American with Disabilities Act came up with back in 1990. And that's because it's our civil rights that protects people with disabilities from discrimination. And that definition is any person with a physical or mental impairment that substantially limits one or major life activities, has a record of such impairment, or is regarded as having such an impairment. Disability is an incredibly diverse group of people. It affects people's sensory systems, it affects learning, their mental health, the mobility, and it can be congenital, it can be acquired later in life, it can be visible or it can be invisible, and actually most people with disabilities have invisible disabilities. And why does this matter? Well, people with disabilities make a large portion of the population. Around the world, the most recent numbers from the WHO was 1 billion people worldwide. In the U.S., back in a study in 2018, it showed that 26% of the U.S. population has a disability. And in one study back in 2012, it showed that 40% of ED visits were by people with disabilities. And it was also shown that many of the people with disabilities were actually high ED users, which was a classification of people who use the emergency department 4 or more times in a year. And I think this is a really important concept in our sort of age of sort of trying to figure out how to best care for people with disabilities is this concept of ableism. And ableism has many definitions, but the one I really like to use is it's a statement or behavior or an institution, policies, laws directed at a person with a disability that denigrates or assumes a lesser status for the person because of their disability. And ableism is sort of throughout our healthcare system. And I guess it's especially problematic because it sort of operates in the background. It's how our system was set up. A lot of the time it wasn't set up with people with disabilities included in the process of how the healthcare system was created. And it sort of operates in the background as a part of implicit bias as well. So it can undermine our best practices and negatively impact health outcomes without clinicians even realizing it. And so if we can see here, there's environmental barriers, organizational barriers, and if you look at, this is a really great diagram from the CDC, which shows we actually don't have a lot of the data about our healthcare for people with disabilities, which I think is really important to prioritize and do more so in the future. We have spaces where we do clinical practice where they're not actually accessible to people with disabilities. We don't have wheelchair accessible rooms. And then finally, from a provider standpoint, there is implicit biases that people have, and it's really important to make people aware of that and to try and improve that so that we can improve patient care. In terms of healthcare disparities, people with disabilities face a lot of healthcare disparities in the U.S. 1 in 3 people do not have a usual healthcare provider. 1 in 3 people have an unmet healthcare need because of the costs in the past year. And 1 in 4 did not have a routine checkup in the past year. And because primary care is so important, this leads to a lot of healthcare disparities when it comes to chronic disease. In terms of this, people with disabilities are 3 times more likely to have heart disease, stroke, diabetes, or cancer. They're 2 more times likely to smoke. Additionally, because of issues with access to care, they're less likely to get screening as well, less likely to get mammograms, less likely to get pap smears, and this is all issues in terms of barriers to care. So, I'd like to get to our breakout groups now. That's sort of just a broad overview, and I'm excited to sort of bring up our group who's going to talk about deaf and hearing impaired.
Thank you, Richie. I'm Jason Rotoli. I'm APD at University of Rochester. I'm also on the board of ADIM.
I'm Ivy Myerson, faculty at UT Southwestern.
The great thing about doing these talks is that you see people that you know over and over again. So thank you for coming to support us. I just want to start off with a quick icebreaker. So I'm just going to minimize this. So this exercise is designed to give the audience an idea of what deaf and hard of hearing and hearing impaired people have to go through. It's not meant to simulate their life. Just want to put that in context. Oh, thanks. I move around a lot, so I probably should be using this. So what I'd like you guys all to do is take a look at the screen. This is a lip reading activity, and I want you to see if you can figure out what I'm trying to say. I'm assuming most people in the audience here have a medical background, and so there will be some medical terminology. The first time is in half speed, is in real time, and then the second time is in half speed, so you get 2 chances. Let's make it large. Here's half speed. So Corey and Annika, you're not allowed to say anything because you've seen this before. But does anyone in the audience besides these two, and Nancy, you're not allowed to either, have an idea of what I'm saying? Anyone get 50% of it? Anyone get anything? I like where your mind's at, but no. So this is usually the response that I get. And what I said was your chest x-ray shows pneumonia and you need an antibiotic called azithromycin to help you feel better. So all words that we are very familiar with, presumably all fluent in English, we are all fluent in the medical language, and our deaf population is probably not fluent in either one of those. Our hard of hearing population, our hearing impaired population is likely fluent in English, given where you practice, but still the medical words are almost impossible to try and lip read. So just kind of keep that in the back of your mind as we're chatting. And then the only other thing that I'll say before I turn it over to Ivy is that deaf and hard of hearing people have a dual responsibility when trying to seek health care. And the very first thing that they have to think about is there going to be access to communication? And am I going to be able to convey my needs to a provider? And that will have a major impact on where they go. And then obviously they also have the thought, where am I going to get the best care? And so those two things can sometimes be a deterrent, and they can also provide significant delays in treatments, especially time-sensitive treatments. And with that, I will turn it over to you.
Thanks, Jason. What you were mentioning a second ago is an important nuance to appreciate about those who either have hearing loss or are deaf, is that it's not a ubiquitous cohort of individuals that don't have the ability to hear. Rather, it's a little more nuanced than that. You have individuals who use American Sign Language as their primary language. And because language is the backbone of any community, any culture, they've actually developed a culture over hundreds and hundreds of years. Then you have other individuals who have hearing loss, but English is their primary language. And so when approaching a deaf patient or someone who can't hear, the first thing to identify is going to be, well, what is their primary language? Because the strategies and the modalities that you're going to need to utilize to meet the standards of acceptable communication completely depends on what language does my patient speak. So there are different methods, but let's first talk about the ASL patient, right? The culturally deaf, the community deaf, or as we refer to pretty often, it's deaf with a capital D, right? So in this population, in-person ASLs, certified interpreters, are gold standard, right? A lot of us, myself included, in the emergency department where it's busy, it's hectic, you don't have time, we don't have American Sign Language interpreters in the hospital. We usually have to call them out, and it may take another hour or two, and time is just not a luxury we have, so many of us resort to using an iPad. This type of interpreting is called VRI, Video Relay Interpreting, and although it is, it does meet the standard for effective communication, I will tell you right now, the deaf community hates it. And the reason is because you're taking a 3D visual language, right, and you're compressing it to a 2D small iPad screen. Communication is without a doubt compromised. Now, again, we're in the emergency department, and sacrifices may need to be made, but in-person interpreting is gold standard. Next is the concern, well, okay, if we don't have an iPad, the battery's dead, the in-person interpreter is another hour or two away, how do we communicate? And a lot of people resort to using a paper and pen. But again, English is their second language. And so their English literacy it can vary. There's no way to tell. So they may have great English literacy levels, and writing in English may be effective, but that's an assumption, an unsafe assumption that you'll have to make. So therefore, there's like a great anecdote that a surgeon walks into a room, writes down on pen and papers, and that says, "You may need surgery." And in American Sign Language, the syntax is completely different. The grammar structure is completely different. It is not signed English. It's actually linguistically closer to French. But he wrote on that piece of paper, "You may need surgery." And because in American Sign Language time takes precedence, the deaf user who may not have that English literacy level will read this and think, okay, in the month of May, I will need surgery, which is a completely different context. That's a completely different message, right? So again, communication, effective communication is a two-way street. How is your deaf patient who may not have high English literacy levels decoding what you're saying? And then when you think about the other cohort of deaf individuals, those who have English as the primary language, but don't have the ability to hear, your strategy can change. There are things like CART, which is, it stands for Communication Access Real-Time Translation. It's basically dictation. There's apps for this, Google does it, but it's real-time dictation that displays it in written form. That is an effective, efficient way to communicate with these individuals. But of course, you want to meet their needs. So do they wear hearing aids? Let's utilize that. The emergency department's a loud place, right? So trying to accommodate their needs and using whatever their primary language is paramount. The other, what's been interesting with the pandemic lately, and has been a big issue in the deaf community, and those who use American Sign Language, and even those who are English speaking but have lost their hearing, is masks, right? And although lip reading is not effective, grammar and syntax in American Sign Language is completely given in the face. For example, I can just look at you with a straight face, point to my wrist, and for example, what do you think I'm doing or saying in sign language? Something about time, okay. Now, if I change my facial structure, for example, and I lower my eyebrows, the meaning just changed. The sign is exactly the same, but the meaning changed. That's the syntax and grammar in American Sign Language. Now, if I do something else, like raise my eyebrows, you're late. Do you know what time it is? Let's go, right? So that's an American Sign Language. So when we have masks, it's like speaking English garbled up, and it's hard to understand. And so there's been a lot of cool inventions since the pandemic where we use these masks that are clear, and it provides a little bit of a window into more effective communication. And then the other, well, I'll pass it off to Rotoli, Jason here, to talk about the attitude barriers. So
The only other thing that I'll add to what Ivy said is the use of interpreters is a gold standard. In-person qualified interpreters, the term qualified is very vague because an interpreter can have a certification, but their qualifications to interpret in a medical setting may not necessarily be there. And that's the risk of using an outside agency, of using the interpreter in an iPad. So they have their certificate of interpretation, but they may not have any background in medicine. And that's the equivalent of like every medical student who graduates from medical school is a doctor, but none of them are qualified to take care of patients. So kind of keep that caveat in your mind. So I want to talk a little bit about attitudinal barriers and some of the biases that we as healthcare providers have and some of the negative perceptions that we maybe portray to our deaf and hard of hearing patients. I think one of the big things that we tend to do in any non-English speaking patient is an over-reliance on the family and sort of expecting family or friends who are proficient in the patient's language to interpret. And in the emergency department, I understand how special the place is, and sometimes that is 100% necessary. But for a non-emergent condition, or for a very sensitive condition, it can really change the information exchange, and it really violates the patient's privacy. The other thing I think that providers do is they approach the deaf or hard of hearing patient with the medical model of disability or the medical model of deafness. And that is to say something that is a problem and something that needs to be fixed. Instead, we would recommend approaching someone with the cultural model of deafness or the social model of disability. And that is to say that society is arranged in a way that prevents this person from functioning at their maximum capacity. And so it takes the onus off of the person, takes the problem away from the person, and it puts it on society to help make accommodations for that person. Really common examples of the medical model of disability and deafness have to do with providers asking a patient over and over about their hearing loss, asking them why they don't use a hearing aid, asking them why they're not getting a cochlear implant when they're in your room because they have chest pain or because they have ankle pain. And then one other thing that we tend to do is sort of ignore our patients' communication preferences. Someone will have prefer to speak through the use of an interpreter, and we don't have one. It's going to take too long. We're just going to kind of try and lip read, or we're going to write back and forth. And again, information exchange is really changed when that happens. Go ahead.
Yeah. So when discussing environmental barriers, again, so the emergency department is noisy, right? So those who rely on English as their primary language but don't have the ability to hear, yelling even louder than the alarms that are beeping is not going to be an effective strategy. And then in terms of American Sign Language primary users, so for example, space is very important. So are we opening up the rooms? Do they, because is vision is impaired by any? Are there a bunch of walls that impair sight to what's going on? I can tell you anecdotally, growing up in a deaf family, when my parents bought houses, they bought the most open layout they possibly could. And there's a reason to this. It's because if there's a wall there, they don't know what's going on behind that wall. And lack of privacy. So American Sign Language, you can't really whisper, right? I can see across the room if someone's signing, and you can impose, you can infer, and violations of privacy can occur. You can use this to your benefit, though. I can tell you many times in training, Jason and I would talk across the emergency department, and I would ask him questions of how to do this through glass barriers and get the information I needed. So you can use it to your benefit.
And the only other thing that I'll add to Ivy's comment is that the rooms, especially in academic medical centers, are so small. And if you think about needing visual communication for your deaf or hard of hearing person, trying to figure out who's talking, trying to get full view of that facial expression is really, really challenging. They're just not designed to accommodate a visual language. So we're going to shift gears and talk a little bit about some evidence-based strategies for institutional changes, or sort of larger scale changes that can impact more than just individual practice changes. There has been a lot of literature in different realms of medicine, so pharmacy, nursing, within the hospital, pre-hospital care, to suggest that cultural awareness or cultural sensitivity training is an effective way to improve provider comfort with someone with a different culture or language, to improve patient-provider rapport, and to improve patient satisfaction, which hopefully will lead to treatment adherence. And the same is true in this population of people. There is a caveat. If this is done poorly, it will simply just magnify stereotypes and reinforce othering. But if it's done well, it can really improve the care our patients receive. Excuse me. It's important when thinking about having your colleagues do cultural sensitivity or awareness training to emphasize that this is a multidimensional problem, and that things like cross-cultural training and knowing about the intersectionality of the person's health problems are really important. And what I mean by that is, like the graphic that Richie showed, there are interpersonal causes for disease, there are societal causes for disease, there are environmental and certainly institutional things. And when you design something, you want the training to be experiential, so not boring. You want it to be dynamic. You want it to be recurring, so that you're catching new staff or reminding old staff over and over, because people do have short memories. And in my personal opinion, you want people to have the option of what to do. So do they want to participate in a small group activity? Do they want to do something asynchronous completely by themselves? Or do they want to do a community outreach or a community event? That last one is really a way to take awareness and move it toward advocacy and something active. What this does is it helps to change culture so that new norms are developed. So things like asking a patient their communication preferences or how they communicate the best is just what we do with every patient. Asking or knowing that you have to have face-to-face interaction and appropriate visibility with a patient is most likely going to benefit everybody, but creating that new cultural shift. And the other really important thing to help change attitudes and biases, provider biases, would be to increase healthcare workers who have disability or who have disabilities or who are deaf. There's a real benefit to doing that, in that these people are experts by experience. They can teach you in an informal way or in a formal setting such as this. And they also have connections to the community. And so you can engage the community in trying to figure out what are best practices and best strategies in implementing institutional changes, so it's not looked at in a ableist or autist way, meaning that we are hearing and normal development and we know what's best for the disability community. Unfortunately, that is not true. And so engaging that community is incredibly important.
Pass it off.
Yeah, we can pass it off. So if you guys want to take a look at these masks, please do. And the last thing I'll say before we pass off to the next group is that integration of these improvements is incredibly important. If they are tacked on at the end of the day, or they're just sort of like an extra thing that people use once in a while, they're going to be dysfunctional. They're going to appear like they're not really part of the system, and the patient is going to recognize that they really didn't try to make an accommodation for me. All right, and so we're going to hand it over to Pyle, Annika, and Jeff.